Good afternoon. Thank you, IMSCON. Thank you, Dr. Juhi and Dr. Shashi and Dr. Madhuri for this wonderful opportunity. So basically, I had even got botulinum toxin and the needle, but unfortunately, there wasn't an appropriate case to do it, so I cannot demonstrate it live, so I will be showing you the video. So we're going to look at what are the goals of management. When does botulinum toxin come into play in a case of overactive bladder? What is the place of it? What exactly does this molecule do? What are the evidence-based clinical studies available to back up the usage of botulinum toxin, and a summary with the video as well. So we all know overactive bladder is a unique problem, especially within the context of a menopausal woman, where frequency more than 8 or more visits to the washroom, urination at night, or 2 or more visits to the toilet during sleeping hours with a sudden sense of urgency, and without reaching the washroom, they might leak during that urge feeling, and an involuntary loss of urine, which can all contribute to the symptom complex of overactive bladder. They can be dry overactive bladder when they do not have incontinence but have urgency and frequency, but when they are associated with a leak along with the sense of urgency, it is known as wet overactive bladder. So what is the difference between a healthy bladder and a bladder which is kind of annoying and irritable? The bladder normally can hold up to 300 to 500 cc. Many of you have not gotten up for a washroom break, but if you did, you probably have already gulped 3 cups of coffee or tea since morning. So empties less than 8 times per day. You don't get up in the night to relieve yourself, and after gradually filling, urge is felt, not something at 100 or 200 cc. However, if your bladder is playing up, you would empty your bladder more than 8 times during the day and wake up at least 2-3 times in the night, and you will have a sudden compelling urge to visit the washroom even when the bladder is half full, so your capacity is not as great as 400 to 500 cc, which is usually a 3 to 4 hours gap. So definitely it does impact your quality of life, especially in terms of physical and psychological, especially lack of self-esteem and lack of confidence. You would be always watching where the toilet is before you enter into any social activity, which is called toilet mapping in your mind. Going to the temple, search for the toilet. Going to the mall, search for the toilet. Going to the cinema, first let me empty your bladder. So similarly will be the stress upon you, which leads to a psychological impact. Definitely social exclusion. Many elderly women do not even visit any relatives. They cannot stay overnight. They cannot travel overnight in a train. Imagine getting up. I had a recent experience when I was traveling by first class in train, and opposite me was a grandma along with her grandson sleeping. 3 o'clock, she got up, she was waking her grandson. Grandson was fast asleep. She leaked completely in the compartment. She was so embarrassed, she started crying. Such could be the effect of overactive bladder. There are definite domestic implications. Your carers know about the difficulty, especially if you have an aging mother-in-law or a mother. They find it very hard even to reach an ensuite bathroom, which there is in the bedroom. And definitely absence from work, decreased productivity, and they avoid sexual intimacy and contact because of the fear of leak during sexual contact. So a detailed medical history, all that you need. I always tell very often in my urogynecology lectures, urogynecology is the cheapest super specialty of gynae to practice. You do not need anything but listening ears and a lot of empathy. That's about it. So detailed medical history, listen to your patient, the way they're walking in, because mobility is an important factor which contributes to urgency, urge leak and everything. If they are arthritic, if they're not able to walk fast to the bathroom, they will be leaking on the way to the bathroom. A bladder diary, which the patient does this homework. You don't need to do anything. Ask the patient to keep a record of 3 days of how much they drink, what they drink, when they drink, how much they empty every time, how often do they go, so you can quickly gauge like what is their fluid, what types of fluids. Coffee, tea makes you go to the loo very often, and you will know the diurnal frequency, daytime or nighttime. You will know whether there's nocturia, whether majority of the fluid is put out only during the nighttime, which often happens in age above 70, and you don't need a urodynamics. The bladder diary is the poor man's urodynamics, and you don't need fancy equipment to practice urogynecology. A proper physical examination, including neurological examination, a simple dipstick urine analysis, measurement of post-void residue. All of you are great radiologists and sonologists. Pop your bladder scan, you will know how much post-void residue is there. Ask the patient to go and empty the bladder, come back, you do your post-void residue. You do not even need a Uroflow machine. Job done. And very finally, if nothing gives you an answer, or it's a complex picture, or you're contemplating intervention, then a urodynamic evaluation. And if you're suspecting any stone, a complicated UTI, or a neurogenic bladder, then you will have an upper tract imaging as well. So as I reiterate again, urogynecology is a very cheap subspecialty which all of you can practice. So what are the treatment goals of OAB? Eliminate or improve urge urinary incontinence. Do not promise cure. You will say if you leak 10 out of 10 today, after the treatment, you will not leak 8 out of 10. Some people do leak 20%, but that's the maximum some people can achieve because of various other factors like mainly obesity. Majority of them, weight management is crucial. If you lose weight, even 5%, 70% will become continent, and that is the first thing we need to stress upon. Reduce urgency and frequency, improvement in warning time. So many of them have this urge and they immediately leak. That warning time will be delayed, so they are able to get to the washroom and relieve themselves and not on the way. So basically, pitch the expectation right. Do not hype up the reality. Do not give false hope. Specialized therapy is where botulinum toxin comes into play. It's highly effective, minimally invasive procedure, reduction in bladder pressure, induces stabilization of the overactivity, basically calms the bladder down, and helps the bladder hold better. And in patients with OAB refractory to anticholinergic, pardon me, it appears to be effective, long-lasting, and you can repeat. Most of the time, I do not repeat the overactive bladder botulinum under 18 months or 2 years, and not all of them require. And you have to understand, in the time between the repeats of the injection, they are off the medications, they are off the diapers. So you can imagine the cost cutting which comes with it. People always say these are fanciful treatment, they are costly. Why do we indulge in costly treatments? But imagine it's a one-off and you don't need medications. How many of you agree these medications for bladder are also costly on a repetitive manner? Quite costly. And they're not without side effects. And patient gets adapted to these medications. Patients are still using continence aids. Patients are still using diapers. So that adds to the escalation of the cost. So in effect, it is a one-time cost investment, is definitely cost effective. And it appears to be repeatable as well. So the need of botulinum toxin has, knowing the fact that treatment of OAB with anticholinergic can have a lack of benefit in about 60% of the cases. Why? 2 reasons why patients stop it: dry mouth and constipation. Constipation worsens urge incontinence. So it's a double-edged sword. So you can't jack up the dosing of the anticholinergic as well. Many patients express a wish to change the treatment to another drug, which is what many urologists do. They write a different brand name. In essence, it is the same molecule. Generally, the most common reasons for a change of the medication are lack of therapeutic response or weird side effects, which are really bothersome more than the actual problem itself. So this is what probably everybody will start saying, and not only the cosmetic aspect, but also in the urogyne clinic. So it has been actually taken over from the dermatologists and more so the neurologists as well. And now it has come to play as an important step in the management of refractory overactive bladder, and definitely a boon in cases of neurogenic overactive bladder as well. So these are the types of botulinum toxin, and we use botulinum toxin A, which is most common and most potent, and definitely translate into beneficial therapeutic effect. It's preventing basically the neurotransmitter release from the presynaptic neurons. So there's no acetylcholine to actually act upon the detrusor muscle. So the detrusor muscle doesn't act. What happens when you do anticholinergic? The detrusor muscle's anticholinergic effect prevents the detrusor muscle contraction. So it becomes flaccid. So one of the side effects can be acute retention. Whereas here, the acetylcholine release itself is trapped. So there's no transmitter to go and stimulate the bladder muscle, and therefore it acts much more effectively. So single-use, sterile 100 units or 200 units, vacuum dried. It's a lyophilized powder which you reconstitute with sterile, preservative-free sodium chloride injection prior to the actual installation. So we use it for either detrusor activity or in patients with a lot of neurogenic problems. I get a lot of patients from the neurology department post-stroke, especially Parkinson's, multiple sclerosis, and spinal injury. They have a lot of difficulty because the mobility is significantly disturbed and the urgency is so severe that they go to the loo at least 20-30 times. Imagine the mobility restriction and the diaper rash and the incontinence. It's a burden for the carer, so it's a boon for the treatment of neurogenic overactive bladder. So injecting botulinum toxin needs a rigid cystoscope using a GA, day patient, and more precise. You don't need to keep the patient in the hospital. You can also use a flexible cystoscope using the local anesthetic and in an outpatient clinic, and it's quite well tolerated. So this is how we do. You can inject in the operating sheath through a Cook's needle, and we do that. This is the bladder look when you do a cystoscopy. The one on the right shows the bladder template fashion in which the botulinum toxin is injected within the bladder in a sequential fashion from top to down, leaving at least 1 centimeter space above the ureteric entry. We do not want to inject it in and around the ureter because that can cause reflux of urine back into the ureter. We used to, in traditional teaching, try to avoid the trigonal space. But there are indications now where we do inject in the trigone, especially in patients with interstitial cystitis, where sensory urgency is the main problem. So we do inject some in the trigone as well, between the interureteric space. I'll show you that. Is this pointer working? This space is done when there is bladder pain syndrome or in cases of interstitial cystitis. We tend to avoid in and around the ureter, leaving at least 1 centimeter above and keep going in a template fashion. Don't start here because it will start bleeding. Start from above and then you do. Is this a video? This is how we, where's the video? Yeah. Can you play the video? This is showing the reconstitution of the botulinum toxin. There is a dilute 0.9 sodium chloride injection, which is taken up in 3 different syringes. I'm doing her 200 units for a neurogenic overactive bladder. I take 2 ml in each syringe and reconstitute each vial and then dilute it up to further 8 ml. So each syringe will have 10 ml. I will then be injecting 1 ml per bleb within the intradetrusor space or the submucosal plane. I generally alternate it between 1 injection intradetrusor, 1 injection submucosal. So the whole bladder mucosa is then covered. And do not agitate the bottle because it's a lyophilized powder, so no foam should be there, no frothing should be there. It'll be like a swirling of a wine glass. So don't shake it, don't agitate it, because the lyophilized powder will not get reconstituted. These are very, very important practical tips when you follow. Otherwise, you will lose the toxin, and what requisite effect of this toxin is there for medical purposes will not be achieved. And remember, these are cost involved, so you will lose the actual therapeutic effect. So gently swirl it. Now you have 3 syringes, each having 10 ml. We empty the bladder. This is again a very important thing. I always do urodynamics before any intervention, be it TVT, TOT, intravesical, Botox, or sacral neuromodulation. When you do intravesical Botox, the capacity of the bladder should be at least 200 cc. If it's less than 200 cc, there's no point doing an intravesical Botox because it does not change the capacity of the bladder. These patients will need what is called augmentation cystoplasty. So there's no point doing a Botox. So always after your urodynamics in the theater, do assess your anesthetic capacity of the bladder. If it's less than 200, she will not be a candidate for intravesical Botox. Now look at this. This is the Cook needle which I have inserted through the cystoscope, and I'm injecting the Botox in every single branch of that trabeculation which is there within the bladder. Trabeculation inside the bladder is a sign of overactivity of the detrusor. So when you see trabeculation, it is not a sign of bladder outlet obstruction. It is in turn a sign of detrusor hypercontractility. So we keep injecting in every single branch of the detrusor trabeculation as well as the submucosal area. Is the thing finished? Can you replay that again? No, the last part. See there, it'll keep creating a jellyfish-like bleb. That shows it is in the right plane. So we keep injecting that in 30 different sites within the bladder. That covers the entire bladder area. Then you leave in an indwelling catheter if need be. Then remove the catheter after 6 hours. Always do it under IV antibiotic cover. When you remove the bladder, just make sure the patient voids at least twice and ensure your post-void residual volume is less than 150 ml before you discharge the patient. Thank you. We can stop the video. So there are side effects to overactive bladder: urinary tract infection, dysuria, urinary retention, but they are all under 10% and increased residual volume, which is why I want you to do it under IV antibiotic cover. Make sure you do trial without catheter and you do a post-void residual volume. And who receive concomitant treatment of botulinum toxin, they should not be doing it for their dermatological reasons or cosmetic reasons or neurological reasons. Always try to avoid gentamicin in your preoperative antibiotic. It can potentiate the effect of botulinum toxin. And patients with myasthenia gravis who come to me, I tend to underdose the botulinum or inform the anesthetist I'm doing it, so their other medications are also titrated. Never give them muscle relaxants like diazepam. That is also very important. Midazolam, I don't ask the anesthetist to give at that time. We don't have the thing in pregnancy. I've not used it in pregnancy at all, but 3 months after pregnancy, we have used it in a spinal injury patient. It is quite safe in breastfeeding. We have not used it under 18 years, but 20 years, there was a patient with multiple sclerosis who had botulinum toxin. Imagine at that age having multiple sclerosis. It is so disabling, especially with added urinary incontinence. Have a lower threshold for neurogenic patients because the quality of life improves significantly and you save the kidney. The main reason why we do it in neurogenic bladder is when the bladder develops a lot of pressure in neurogenic detrusor overactivity, what goes off is the compliance of the bladder. The bladder is supposed to be like a distendable elastic balloon. It's not supposed to build pressure when it fills. But in neurogenic bladder, the compliance is restricted. The bladder builds up pressure. That pressure is transmitted backwards into the kidneys, and that forms hydronephrosis and very early renal damage. That should not be the case, and that is the main reason why we do intravesical botulinum toxin in a neurogenic detrusor overactivity. So always use it and keep it in the fridge. We do not reconstitute if it has got particulate matter, and do not use after the expiry. But unopened vials of botulinum should be stored in a refrigerator for up to 3 years. You can't use it more than that. I've already mentioned the initial dose is 100 if it is an overactive bladder, but for neurogenic, we use up to 200 to 300. It's injected into the detrusor muscle or the submucosal space. The distance which we go, or the depth which we go, is about 2 millimeters, and either 20 or 30 injection. Give a space of about 1 centimeter distance between 2 injections. So these are the various evidence-based studies where they were assigning patients to either have a placebo or botulinum toxin, and looked at the incontinence rate as well as reduction in the urinary incontinence episodes at 3 months. As you can see, there was a significant improvement in the botulinum toxin group. So showed significant clinically relevant improvement in all overactive bladder symptoms: frequency, urgency, urge leak, and quality of life in patients with botulinum as compared with anticholinergic. It also provides significant improvements in overactive bladder symptoms regardless of the number of anticholinergic. It's not something like one drug, combination drug, high dose drug, 3 drugs, doesn't matter. It still has a cutting edge on top of any medical treatment. This is what has been established in this particular review as well. So more than 3 anticholinergic also, it significantly improves. It's not that your bladder is doomed. You've failed all medical therapy, you still have hope, you still can get better. This is again a reduction at week 12 compared to placebo in patients who have not used it, and 100% improvement in the botulinum toxin group. So in patients with symptoms of OAB who are inadequately managed by one or more anticholinergic, botulinum toxin provides significant similar treatment benefit and safety profile regardless of the number of prior anticholinergic or reason for inadequate management of OAB. This again, all idiopathic overactive bladder symptoms definitely were improved with botulinum toxin. This was another randomized double-blinded placebo-controlled trial. So in essence, botulinum toxin is hope for the patients who have lost their confidence, lost their self-esteem, still troubled by incontinence. So do give them this option. Do not tell them nothing can be done. This is how life is going to be. This is how menopause is. No, this is just a stumbling block, and we still have a good road ahead. Thank you for the opportunity. Pura package ke liye. I'll tell you for the 100 units vial, it's 19,000. 19,000 plus your GST or whatever. You can get at a reduction price provided your hospital pharmacy is able to get. There are 200 units which will come at around 30,000. So the Cook's needle is disposable. In India, everything is jugaad. Ideally, it's disposable, but you can use for 10 cases. And a rigid cystoscope is a one-off investment. The whole procedure lasts for only 20 minutes. Your theater time is only half an hour, maximum. And you do it under short GA. You need a single dose antibiotic. I always give 5 days broad spectrum antibiotic to prevent the UTI. And that's about it. So your total package will come under about 1,25,000 for your tariff for your hospital.
Thank you so much, ma'am. Thank you.
Gentamicin, amikacin. Generally avoid aminoglycosides and fluoroquinolones in all the urogynec cases because most of the bacteria have become resistant to this, and these have serious side effects, especially in our elderly population. Fluoroquinolones cause a lot of depression, diarrhea, quad syndrome, and the aminoglycosides pack off the kidneys. So try to avoid them.
Thank you so much, ma'am. Ma'am, we'll take questions later because now our screen is going to start. We are now.
Yes, I have. I have a spinal injury patient where I've repeated 3 times. I've delivered her after the second injection and repeated the third injection because she had a roadside trauma, fell off the bike, and I've delivered her by cesarean, and the third injection 6 months after her second delivery.